This is Dr. Ben Weitz with the Rational Wellness Podcast, bringing you the cutting-edge information on health and nutrition from the latest scientific research and by interviewing the top experts in the field. Please subscribe to the Rational Wellness Podcast on iTunes and YouTube, and sign up for my free ebook on my website by going to drweitz.com. Let's get started on your road to better health. Hey, Rational Wellness Podcasters. Thank you for joining me again today. Dr. Ben Weitz here, and I'm here with a very interesting guest, Dr. Kent Holtorf, and we're going to talk about fibromyalgia and chronic fatigue problems. Dr. Kent Holtorf is a nationally recognized expert on fibromyalgia, chronic fatigue, and thyroid problems. He's the medical director of the Holtorf Medical Group, and he has affiliate centers across the country. He's also founder and director of the nonprofit National Academy of Hypothyroidism, which is dedicated to dissemination of new information to doctors and patients on the diagnosis and treatment of hypothyroidism. We're going to speak to Dr. Holtorf today about fibromyalgia and chronic fatigue syndrome, two related and very difficult to treat conditions, often affecting women and affecting quite a number of people in the United States. Dr. Holtorf, thank you for joining us today.
Thank you so much. Pleasure. Thanks for having me.
How did you get interested in treating chronic fatigue and fibromyalgia?
Yeah, well, basically, I was a very standardly trained physician, and going through medical school, I got so fatigued. I was like, something's wrong. Went to the doctors. I said, oh, you're stressed out like the other, students. I'm like, that's not it. Oh, you're depressed. And they treated that. I'm like, that's not it. And just basically worried about functioning. Went on to residency, and it got very bad. I'm like, I don't know if I can see patients. Now, you're kind of trained in medical school. The alternative is quackery and all this. So I'm like, I'm not getting help here. I'm going to go to some of these so-called alternative conferences. And I realized, oh my God, they are more evidence-based than what I was learning in residency. And basically, I treated myself with thyroid was the big thing, little adrenal support, cortisol, growth hormone, testosterone. Oh my God, I'm a new person. And so I was able to function. And then I was doing anesthesia, got out of that because I'm like, okay, this is so boring. But because I had the energy after that. And then a number of years later, it was doing fine, went through a stressful divorce, just crashed. And we were treating Lyme disease at the time, like, I know it's Lyme. This is just too bad, not just chronic fatigue syndrome, but a lot of chronic fatigue syndrome was Lyme. And then I went into heart failure. My blood was so thick, you could not pull it out. And when I found him, I did 4 years of the highest dose IV antibiotics that I would never even give a patient. I'd stop for 2 weeks and come back. So went essentially all over the world looking at treatments, and I found that really immune modulation is the cornerstone of successful treatment, because all these patients just, they get a little better or worse with these antibiotic treatment, but if you don't treat the immune system, that's the key. That's what you need to do for long-term improvement.
So what kind of treatment did you do to balance the immune system?
I did so many treatments. A lot of things work, but and so each thing kind of works for different people. Ozone was very helpful, but we really found umbilical cord stem cells great for immune modulation, lowering inflammation, and peptides, which is a new therapy that's becoming, again, a cornerstone of our therapy. And really, so what you see is what happens with chronic illness, especially chronic fatigue syndrome, chronic Lyme. There's two sides to your immune system, Th1 and Th2. Th1 gets stuff inside your cell, Th2 gets stuff outside. So normally they're balanced. With chronic Lyme and what Th1 gets suppressed, then your body increases Th2 and all this inflammation and symptoms. But if you don't increase this, modulate that immune system, then its long-term success is very difficult.
Yeah. And then isn't it also important to stimulate T regulatory cells as well?
Yeah, all that goes into it. And the immune system is very complex. The Th1, Th2, is a way of looking at it. We're practitioners. It makes sense. And what you really see, for instance, HIV, you look at who progresses in HIV, directly correlates with how low the Th1 and how high the Th2 is. So it really shows with these chronic infections, we're beating on people with these antibiotics, antivirals, and if you don't address the immune system, you never get there because the immune system's so low, you can get the antibiotics down, but the immune system has to basically take over. Because most people that have chronic Lyme or chronic infections, they basically are able to suppress the infection, even though they have it. So for instance, like getting chickenpox. You say, well, I'm over the chickenpox. You're really not. The body just basically hasn't suppressed it, comes back out as shingles when your immune system's low. So it's a good model for, hey, keep the immune system high and you don't get shingles again. Same thing with Lyme, chronic fatigue syndrome, fibromyalgia.
Yeah, it's interesting. I interviewed Dr. William Parker last week, and he was talking about using worms that you ingest and live in your intestines, and the main effect is to help regulate the immune system.
Yeah, and those are great, as you said in your previous podcast, where they're great for autoimmune diseases of the gut. You find that third world countries don't get Crohn's and ulcerative colitis because they have these worms. So yeah, that modulates the immune system. Same thing, increased Th1 lowers that Th2, and we find, we haven't used worms, but they seem like they fit right in with the model.
Yeah. So you've written that one of your articles on your webpage, you write that central hypothyroidism and cellular resistance to thyroid hormone exists in the majority of patients with fibromyalgia and chronic fatigue syndrome. What did you mean by this? How can this be tested for, and then how does it get treated?
So when you look at studies that use like TRH tests, so most doctors, they basically look at TSH. So the TSH, the basic TRH produced in the hypothalamus, tells the pituitary to secrete thyroid stimulating hormone, which then tells your thyroid to secrete T4, which then needs to go into the cell, convert to T3. So all these things need to happen. Now, what do most doctors check? The TSH, which tells the level in the pituitary. So when the pituitary level goes up, the TSH goes down. When the pituitary level goes down, TSH goes up. Now, what we found with chronic inflammation, chronic infections, diabetes, dieting, obesity, what happens is the pituitary is different than every other tissue in the body. When it has, you have all this inflammation and this chronic illness going on, the pituitary levels go up, but the rest of the body goes down. So what happens is you get low TSH, what doctors will say, they're taught that thyroid's very easy. If your TSH is high, your thyroid's low. If TSH is low, your thyroid's high. It's normal, it's normal. Find that is not the case with so many illnesses, especially chronic fatigue syndrome, fibromyalgia. For instance, they did TRH testing in fibromyalgia patients. All of them were low, even though they had a TSH that was low normal. So it looked like they had a little bit high thyroid. So it is totally inappropriate to use TSH in chronic fatigue syndrome, fibromyalgia. Also, we're finding diabetes, anyone with chronic dieting, any autoimmune disease, inflammation. So all these things, the standard blood test we're using is missing about 80% of people with chronic illness.
That's kind of a controversial viewpoint, though, isn't it?
Well, it is, because we're just taught over and over that the TSH is what you look at. But I've published numerous reviews on this with hundreds of references from standard medical journals. It's clear, it shows it. And when you show this data to people, like, why haven't I heard this before? I'm like, it's very complex. Doctors learn what they learn. And, basically you look at the studies, most doctors are practicing 20 years behind what's available in medical literature. And they did a study and they found that it takes on average 17 years for a proven new concept to be accepted in mainstream medicine. And they said, why is that? They said, one, doctors don't read medical journals. They don't have time. And if they do, they read the abstract of the whole thing. But also drug reps basically drive doctors prescribing. But the biggest reason was they found that if you give a doctor, here's a study, here's 5 studies, 10 studies, 100 studies showing what you're doing is wrong, they don't want to read it. They say, no, what I'm doing is fine. They don't have time. When you look at all these tests we're doing for thyroid, you can't just do the blood test. Doctors are like, I don't have 15, 20 minutes to spend with the patients and ask them all their symptoms. They have, 9 minutes now. So what do you get? You get an antidepressant. If your TSH is high, you get Synthroid, which doesn't work very well. Or if it's normal, okay, you're just depressed or stressed, go away, you're done. So that's a really driving force. No one wants to take the time when it does to basically treat thyroid appropriately.
So what are the best tests to get an accurate measure of thyroid?
Now we're developing a new test called the bioactive TSH. You find with, again, that pituitary dysfunction, your body secretes less active TSH, but that's not available right now. That's up and coming, hopefully.
Active versus inactive TSH?
Yeah. Yeah, and the standard test just picks up the amount of TSH, not the activity. So you can see if you have chronic illness, the TSH may be the same, but it's less active. So we're working on that for 10 years, and but we're made some progress. But we look at, so you need to look at the free T3, free T4 levels, but one key is the free T3 reverse T3 ratio. So the body will take T4, which is inactive, secreted by the thyroid. It can either convert to T3, which is active, or reverse T3. So reverse T3 is the same thing, but backward. So it goes to the cell receptor, sticks there, but doesn't do anything. So they say, well, it's inactive, but actually it's blocking the active thyroid. So it's a brake pedal for the thyroid. So with stress or chronic illness, inflammation, chronic infection, you'll make high reverse T3. So if you look at the free T3 reverse T3 ratio, it's a very good marker. Now with a little caveat, the new assays out are not that good. They kind of crunch everyone together. Before, 5 years ago, they were very telling. Now they're they're telling, but not everyone wants exact cutoff. We need to look at that. Another marker is sex hormone binding globulin. And people think of that in terms of testosterone because it binds up testosterone. So people will say, well, we want to see what's the free testosterone. So hormones can be bound up or free. The only ones that are active are the free. But sex hormone binding globulin goes up in the liver in response to two things. One is estrogen, one is thyroid. So when a woman comes in, let's say she's menstruating normally, probably normal estrogen, if her sex hormone binding globulin's below 80, they're low thyroid. And also, if you give thyroid and SHBG does not go up, they have thyroid resistance. So that's a key test that so many doctors don't know about, and they just don't think about it.
Interesting.
And symptoms are key. Also, I mentioned, body temperature, low body temperature, symptom assessments correlate very well. We have a computer that measures the relaxation phase of the muscle reflex. So normal thyroid, the reflex will go, but the lower the thyroid, it goes, dun, so the computer measures that. British Medical Journal, obviously major medical journal, showed that test was better than blood tests for thyroid, correlated with symptoms better. Then we'll also check everyone's basal metabolic rate. And we'll find most people come in that have symptoms.
How do you measure their BMR?
So basically with a device that measures the oxygen output, over 10 minutes, and it extrapolates for the whole day. So it tells you how many calories you burn, how much oxygen you utilize equals how many calories you burn. And, let's say my metabolism is low, everyone's like, yeah, right. They're usually 25% lower. So that correlates about 500 calories a day. So they either have to, eat 500 calories less just to stay even, or exercise for about 2 hours. So, or fix your metabolism. So we find that as a gold standard for basic metabolism, which equals the thyroid. The thyroid is the gas pedal for the metabolism.
Right. So you've also written that most patients with fibromyalgia and chronic fatigue syndrome suffer from clinically significant adrenocortical dysfunction due to hypothalamic and pituitary dysfunction. And I see from some of your articles that you often treat both of these conditions with low-dose cortisol. How does this help? And maybe you could explain the mechanism.
Yeah. So the adrenals, as you know, basically a lot of people know it's a stress response. It helps your body deal with stress. Now you look at the study. Now so many people say adrenal fatigue. I think that's overused. That
right. That seems to have been sort of critiqued, right?
Yeah, and everyone's kind of like, okay, adrenal fatigue, But when
do you like the 4-part adrenal cortisol testing with the saliva?
I do. That way, because a lot of times you'll see it. They're not. In fact, when are they low or high? But it should be high in the morning and then come down and low at night. But you'll see people completely opposite. They don't sleep and they're tired during the day. So I think that is a good test. We'll do a lot of blood tests because we kind of been doing it a long time. We don't need to do those things, but they're certainly useful because you get multiple times during the day. But what happens with chronic infection? We talked about pituitary dysfunction with the thyroid. Same thing happens with the adrenals. So pituitary secretes ACTH, which tells the adrenals to go up. Now, what we find, it's usually not a primary adrenal problem, it's a hypothalamic pituitary adrenal problem. Now, normally what they did was do ACH stimulation tests, which is considered the gold standard for adrenal dysfunction, and they found no difference in chronic fatigue syndrome fibromyalgia. But the problem is that only tests for primary. But when they did central testing and found that there's, again, hypothalamic pituitary adrenal dysfunction, which these tests showed up, 90+% actually had HPA axis, hypothalamic pituitary adrenal dysfunction, and responded very well to treatment. And they found that the ACH stimulation test was no better than flipping a coin. So again, that gold standard testing missed 80% of them, was no better than flipping a coin. So, and it's very hard to do the central stimulation test. So, but if you look at the studies, for instance, the Journal of Infectious Disease in Brazil looked at chronic infections, what the adrenal function, how it correlated to serum levels. They found if they were lower than 12.6, they had about an 85% chance of being low adrenal. Because when you're sick, you should be higher, right? Let's say, what is normal adrenal function? Depends on the person, depends on the stress. If you're in the ICU and have a normal adrenal level, you're probably going to die. So you need much more during times of stress. So with chronic infection, you need more. And so that's just a quick and easy test to do for adrenal function and say, hey, is this person low? Look at all the symptoms. Giving low-dose cortisol, everyone's like, oh my gosh, as an endocrinologist, it's safer than actually doing the testing. Basic stimulation test, much safer, does not suppress the adrenals. Actually, at low dose, it will improve adrenal function. And then as you treat everything else, that will get better. So usually we'll treat for 3 to 6 months, or it depends on the case, but they're often not on it long term, and like a lot of adrenal support as well, and that often comes back.
Yeah, I guess a lot of us have seen patients who are on prednisone for a long period of time for asthma or some other condition, and and they have all these side effects and loss of bone and all kinds of other things. So I think that's where the worry comes from.
Written on this about the low dose, completely different, and I can't remember the last time I gave prednisone or any high dose, because you're basically doing a disservice to the patients, suppressing their adrenals. They got to be on it. It's all the side effects. But again, optimal is optimal. Prednisone is mega doses, which it's going to have issues.
And does it matter if you use cortisol or cortisone? Those are different, right?
Yeah. Well, so cortisol or hydrocortisone are the same thing.
Okay.
Those are interchangeable. Yeah. We use time released, compounded.
Okay. So you've also written about lower levels of growth hormone being correlated and being a contributing factor in fibromyalgia and chronic fatigue syndrome.
And again, the same thing, growth hormone produced the pituitary, usually at night. Then it goes through your liver, increases IGF-1, insulin growth factor, which has a lot of effects on the healthy immune system, weight, all those things. And just like everything else, again, when you look at these chronic illnesses, everything from the pituitary controls, which is a lot of things, are dysfunctional. So studies by Bennett from the University of Oregon found that giving growth hormone, dramatic improvement in symptoms. And growth hormone is very controversial and very regulated because athletes using it for performance, which shows that it does work. So we kind of stopped over the years using straight growth hormone and more using secretagogues that stimulate your body's own production, including peptides we're finding are a key for that.
Like which peptides?
Like ipamorelin, CJC. So I've done a lot of lecturing on growth hormone secreting peptides, growth hormone secreting hormone. Now you'll get samorelin or semarelin, however people pronounce it, but either way. But that is a growth hormone secreting hormone, and it does work, but it stops working after a couple months. So if you add a growth hormone secreting peptide to that, it works much better and longer. And you can't overdose because your body will actually regulate it. And so it's a nice way, very safe, much more cost effective than growth hormone, and you get the effects. It's not great for bodybuilders, which we don't see, but for the sick patient, and usually the sicker the patient, the better the response to growth hormone. And healthy people, they might see some performance, endurance, but usually they don't see dramatic effects. But the sicker the patient, the more they respond, and very well tolerated. I can't remember the last time I had a side effect from growth hormone, or especially the secretagogues.
What about some of the natural methods of elevating growth hormone levels, including certain amino acid supplements, and even heavy weight training has been shown to elevate growth hormone levels?
Yeah, and I think especially those you'll see with healthy patients, and the people that kind of need it the most, those that don't work too well. They usually can't do that stuff. Especially heavy weight training, they're so fatigued. But healthy people can see benefit in those things. Although oftentimes it's highly variable and depends on the person. But those things can work. But usually someone who's very motivated to do those things.
Okay. I see that you often see chronic infections as a factor in fibromyalgia and chronic fatigue syndrome. Which infections do you see most prevalently?
Yeah, I mean, the big thing we're seeing is Lyme, but there's so many other infections that go along with it. And when someone has Lyme, they usually have multiple other infections, including co-infections. But BCA is a huge problem. It makes Lyme treatment so much worse, and the treatments, the symptoms much worse, and the treatment much harder. Bartonella, you'll see, much worsening symptoms, a lot of neurologic. People get diagnosed with schizophrenia and bipolar, and they actually have Bartonella. But also when you see with Lyme, it suppresses the immune system. So you get all of these, they're not new infections, but they're reactivating infections. So such as Epstein-Barr, HHV6, CMV. And the problem is when you test them, so normally when you get an infection, we're taught in medical school, your IgM antibody goes up first, and then after a while, IgG. So you say, well, if it's a new active infection, you should have IgG positive, whether HHV6, Epstein-Barr, but these are not new infections, they're reactivating. So the body secretes IgG. So the higher the IgG, the more likely you have this chronic active infection. But a lot of people are told they don't have these viruses, which not uncommonly, you need to treat the virus along with the Lyme or the other bacterial infection because that's suppressing the immune system. Antibiotics don't touch it. But immune modulation, again, is a key for all those because they're all coming out because the immune system's too low. So let's say whatever antibiotic or antibiotic, you need to get it down to the immune system, but if you get the immune system up, those start working. So they work much better together. We rarely give antibiotics or antivirals without an immune modulator.
Do you use immunoglobulins?
Oh, I love IVIG. And it, again, another immune modulator does the same thing, increases Th1, lowers Th2, can also, kill passively with the infections, but the problem is it's expensive. And so what we'll do typically lower doses, so people can afford it, but it's a great treatment. I wish it wasn't so costly.
What about LDN? Have you used that?
Yeah, I love LDM.
Which is low-dose naltrexone.
Yeah. So Lowdose Naltrexone. I'm on the advisory board for them. Spoke at their conferences many times, and written a couple chapters on LDN and chronic fatigue syndrome fibromyalgia. So your listeners probably heard of it before, but so it's an opiate blocker, and they found it's usually used for people to go to the emergency room. They overdose on opiates, pain pills. They give them that, it reverses it. But what they found at low dose, very low, a low dose, it modulates the immune system. So it kind of does that same Th1, Th2. So it's a first-line treatment, very safe, very little side effects. Some people get a little insomnia with it, but like anything, it doesn't work for everyone. But it's something to try because it's very inexpensive, very cheap, very, very safe.
I noticed in your writings you also talked about coagulation problems, fibrinogen, that kind of stuff is being related to fibromyalgia and chronic fatigue.
And that's another big issue, that if you miss this, you may not get better. And what we found is you get immune activation of coagulation. A number of studies by Berg and others. The infection sets off the coagulation system. The body tries to wall off the infection by laying down fibrin, and the blood gets very thick. I mentioned that you could not draw my blood when I was very sick. You couldn't take it out with a giant needle. And my D-dimer, which is a marker for this immune activation, was so high, it was at about a 50-fold increased risk for a cardiovascular event in the next year. So, I've got to get that down. But so the body lays down this fibrin, covers up the infection, which is good in the short term, but now the body can't get at it. And oxygen that normally takes 2 seconds to get in the cells now takes up to 2 minutes. So the cells are starved for oxygen, hormones can't get through, waste products can't get out. So until you clean up that fibrin, which may be a little bit of blood thinner like heparin, coumadin, and those other, the new ones don't work, or some fibrolytic enzymes can also help. And once you clean that up, it's interesting. We'll have people doing, let's say, did IVs, so it didn't work. You give them a little, clean that up, do the same treatment again. They're like, oh my gosh, it works. So that's one of the keys that I think are missed frequently in providers that are treating Lyme, and it can make all the difference in the treatment.
Yeah, I found a combination of those enzymes along with high-dose fish oil also very helpful.
I agree. And again, multifactorial treatments usually are the key.
Good. So I think that's all the questions I had for you. Anything else that you want to say about by the way, fibromyalgia and chronic fatigue, for the most part, they can kind of be treated as one condition?
Yeah, they're essentially the same. You look at also the diagnoses are crazy, like fibromyalgia, 11 to 18 tender points. There's nothing special about those tender points. And it's like, look, you ask the patient if they're significantly fatigued, have brain fog, sleep disorders, may or may not have muscle pain, they have it. And so you look at the blood test. People will say the standard is, oh, there's no blood test to detect it. We can pick out chronic fatigue syndrome, fibromyalgia on a blood test, on a panel, and how severe it is about 80% of the time. So when people say, oh, there's no blood test, we can pick, oh, this person's going to be, essentially probably bedbound. This person's probably not too bad. It's the blood test tells you. So it's not, everyone's, oh, it's mental, it's made up.
Right.
Yeah.
And so the blood panel basically includes thyroid and cortisol and all these other factors we've been talking about?
Right. It's usually, large blood panel because we like to get all the information because there's so many symptoms that are dysfunctional. We've talked about a couple of them. You got the, pituitary, hypothalamic pituitary, all the hormones, mitochondrial dysfunction, so the cells can't make energy. You have the coagulation defects. You have the gastrointestinal system. So many things. You got toxins that are wrong with this condition. So when you look at studies, people say, oh, it's because of sleep, or it's because of mitochondrial dysfunction, or hormones, or thyroid. Who's right? Well, they all right. And it just depends. You got to find the patient which things are affecting them the most.
Great. You've provided us some really useful information, Dr. Holtorf. Thank you. For listeners and viewers who'd like to get a hold of you, what's the best way for them to get in contact with you?
They can probably call the office. So we're in El Segundo by Los Angeles. We have centers also in Foster City by San Francisco, Philadelphia, and Atlanta. But you can call our number, there's 800 number, which I'm not sure what it is, but we have the 310, our LA number is 310-375-2705, or go to our website, holtorfmed, HOLTRFmed.com, or our nonprofit National Academy of Hypothyroidism, where all these studies that, say, oh, they said my thyroid's normal. You'll see hundreds of references showing that's not true. And that's NA, like National Academy, NA hypothyroidism.org.
That's great. Thank you.